Are you tired of staring at a chest x-ray and feel like you're looking at a blizzard in a snowstorm? Missing a subtle shadow on your ward rounds could mean missing a critical life-threatening diagnosis. Welcome back to Clinical MedEd. I'm Dr. Raza. As a senior consultant physician in internal medicine, I rely on these films daily. And today, I'm going to completely demystify the chest radiograph for you. We are going to build a bulletproof systematic approach so that you never miss a finding again. Let's dive in. So by the end of this video, I want each and every one of you should be to be able to appreciate the image quality and technique so that you don't have to worry about the artifacts on the chest x-ray. Use a systematic reproducible approach like a simple ABCDE approach of interpreting the chest x-ray, and also review the areas which can be easily missed before labeling a chest x-ray as totally normal. And also we will go through some common patterns of the presentation like consolidation, collapse, pleural effusion, pneumothorax and pulmonary edema. And I want you to understand and identify the urgent call now functions and findings on a chest x-ray and device complications so that you can flag them to the ordering physician's stat and ASAP. And at the end, we would go through a simple and concise method of how to write a proper report about a chest x-ray. So let's begin. Some of the basic housekeeping rules. So the mindset, you need to be systematic and safe. So always think like a radiologist, even if you're not. In the chest x-ray, it's really imperative to compare both sides, left and right, and have a visual scanning of both sides. Look for the unexpected. So we'll touch at the end of this video about some of the review areas which can be easily missed. Ask yourself, does this finding fit with the patient's presentation, which will be usually in the request by the ordering physician? And if you're unsure, one of the best pearls is to compare with the previous film if available. Pearl number 2. We will come to the right model later on, but do not be fooled or do not be confused by some of these very common artifacts. Number 1, rotational poor inspiration, which can lead to pseudocardiomegaly finding on a chest x-ray. Also be aware of the AP portable film while reporting the cardiac size. So you can hardly comment accurately about an accurate cardiothoracic ratio on an AP portable film. We'll come to that later. And over and under exposure of the film, because you might miss a subtle pneumothorax due to the exposure quality of the film. And also be aware of the skin folds, nipples, clothing and lines which can create artifacts. Let's look at step 0. You might be wondering, why am I saying step 0 and not step 1? Because this is to reinforce the message that you cannot proceed to the next steps until you confirm all these findings that I'm just going to say now. First of all, please make sure that you are looking at the correct patient's chest x-ray. This is very, very important in our clinical busy life, that we might just look at someone else's report. So this is really crucial. Also look at the date and time. Mix-ups do happen. Also, number 2, look at the projection. Is it AP or PA? We'll come to that later. Is it erect or supine? Is it portable or departmental x-ray? Whether you have the right-left markers properly aligned. Also look at the clinical question posed by the report by the ordering physician. Is it a fever, chest pain? Also, if you have any previous x-rays to compare with, that will be like a gold dust. And in step 0, one of the most important aspects is the projection. And why do I say that? Because the projections, if it's not the right projection and if it's an AP film, it can mislead the reader or physician in that matter about the size of the heart. So it can look bigger. It can exaggerate the pulmonary congestion. So it might appear that there is element of fluid overload or heart failure, which it may not be. And also in supine AP films, it can hide some of the smaller effusions. In the last slide in step 0, we discussed about the projection. So this is really important for us to first understand the common views and projections, the normal anatomical landmarks about with all these views of PA, AP, lateral and special views. So firstly, let's look at the standard PA view. So please remember the PA, which is posterior anterior, or AP anterior posterior. So what does it mean? We are talking about the way the radiations are traveling. Please remember that. So posterior anterior, the radiations are traveling from behind the patient to the front, and the film is placed opposite to the radiation source. So if you look at the figure at the bottom, so close to the heart, so the gray bar is the physical film. Okay, so the radiations are at the back. So that is posterior anterior. Because the film is so close to the heart, the magnification is not that big. So that's why the heart looks more accurate in its size. In terms of the AP, obviously, the film is at the back. The patient cannot move. So the film is at the back, while the device to generate the X-ray radiations is at the front. And when it goes, obviously the heart is farther from the film itself. So when the radiations are traveling, they have to travel a distance to the heart, and by the time they reach the film at the back of the chest or the chest wall, the heart appears bigger. So in this slide, you can see the annotations of the key anatomy is given in the table on the left side. But if you follow the right side of the heart from the right side, on top you have the PTL, the paratracheal line. Then C is the carina, where the the trachea divides into two, right main bronchus and left main bronchus. The angle is a carina. Then follow the follow the carina down. You will see H, which is a hilum. So on both sides it's a hilum. RA is the right atrium on the right hand side, and then follow the right hemidiaphragm to the CPA, which is a costophrenic angle, and then BS is the breast shadow in females. On the left hand side, you can see the AK, aortic knuckle. Then you have what is called the aortopulmonary window, APW, followed by LV, which is the left ventricle, and then CP. So that is cardiophrenic angles. Obviously, you have two costophrenic and two cardiophrenic angles. So where the lung, the diaphragm angle and the cardiac angle, they meet. And obviously, STS is a subdiaphragmatic shadow, where you can also see sometimes the gastric air bubble. Now, looking at the specific cardiac anatomical landmarks, so 1, 2, and 3 correspond to, number 1 is superior vena cava, followed by the right atrium, and then number 3 is the inferior vena cava. On the left side, you can see 4, which is the aortic arch, and then we have the number 5 is the main pulmonary artery, 6 is the left atrial appendage, and 7 is the left ventricle. AP portable view, as we discussed, is usually considered on patients who cannot go to the departments. And as we have discussed before, because of the film is placed at the back, and the X-ray radiations are traveling from the front, so the heart looks bigger, as in this case. Coming on to the lateral view, it's better to localize lobar disease, because on an AP film or a PA film, if you cannot differentiate, is it upper lobe or middle lobe or lower lobe, the lateral view really helps that. It's also good for retrocardiac pathology or shadows to delineate, and also small effusions can be located at the costophrenic angles at the lower end. If you look at the anatomical landmarks, 1 is the left atrium, followed by the left ventricle, which is 2. Number 3 is inferior vena cava. Number 4 is right ventricle, and 5 is right pulmonary artery. 6 is left pulmonary artery, and 7 is the aorta, which is just arching down in front of the vertebral column. Just a little word about the special views. They're not routinely recommended, but some of them are, for example, lateral decubitus view, which is usually for the small pleural effusion which trickles down, and also in expiratory films to look at the small pneumothoraces which cannot be easily picked up in inspiratory films. And lordotic views, which is in this case, is usually for small apical lesions, in case because the lung apex on a normal PA film is too crowded due to the clavicles and the upper ribs, and the apex itself is a narrow part. So sometimes shadowing over there may not be discernible, may not be very obviously visible. So the lordotic view actually helps in delineating that particular part. And so after step 0 and looking at the views, the step 1 actually involves what is called the RIPE regime. So RIPE stands for rotation, inspiration, projection, and exposure. In rotation, we need to look at the medial ends of the clavicles, that they should be equidistant from spinous processes. Other inspiration, you should be able to see at least 6 anterior ribs or more than 10 posterior ribs. To look at the adequacy of the film, that the film is adequately exposed. So it means there should be no missing lung apices, and also the bases of the lungs. And in terms of projection, we have discussed PA versus AP. It changes the heart size, and you cannot comment on the cardiomegaly. And finally, exposure, which means the vertebral bodies should be barely visible through the cardiac shadow. So the first step in RIPE is R, which is rotation. As we discussed before, how do we assess for the rotation? You look at the medial ends of the clavicle and compare the distance of the medial end of the clavicle to the tips of the spinous processes. Now, the spinous processes are visible right through the center of the film, as you can see, and the magnified inset on the right hand side. So and also the medial ends of the clavicle, I've just dotted them with orange colors. If you see on both, on this magnified zoom view and the other one, it's totally equidistant. So if you compare, and if it's the equidistant, it's not rotated. If it's unequal to one side, then you can say it's rotated. And rotation can also mimic mediastinal shift or hyperinflation on one side, or if there's a higher asymmetry. In right, the next alphabet I stands for inspiration. We need to make sure there is adequate inspiratory film, which means we should be able to measure or count at least 6 anterior ribs. So if you look at the pen drawing which I have made on the X-ray with yellow lines, so you can count 7 anterior ribs here. So this means it's adequately inspired film, adequate inspiratory film. Also in terms of the adequacy of the whole film, so the lung apices are visible, and similarly the hemidiaphragms and the claustrophrenic angle, so it's adequate film, so there is no part of the thorax which is cut out. So that's how you look at the inspiration. So for more than 6 anterior ribs, or if you count posterior, it should be more than or around 10 ribs. Coming to the P and E in right, so projection and exposure. And regarding projection, we have discussed in the previous views about the P and AP. You can look at those slides, but essentially AP portable, which magnifies the heart and mediastinum, so you cannot comment on the heart size. In terms of exposure, it means how are the X-ray radiations penetrating. So if it's underexposed, it means there aren't enough radiations penetrating through the chest wall, and hence it looks more sort of a whitish on the scale, while overexposed means there is too many radiations penetrating, and hence it looks more darker or black in color overall. So what's the problem? So air is black, so if it's underpenetrated, you might miss a subtle or small pneumothorax, and overpenetrated means it's more blackish. So if it's overpenetrated, it means the white substance, which is more like consolidation or infective etiology, that will be difficult to pick because it might appear more sort of blackish. So the white tone is now converted more towards a blackish. So that's why you need to be able to look at adequate exposure. So what do we mean by adequate exposure? Now the intervertebral bodies, when you look at the cardiac shadow itself, so within the cardiac shadow, the intervertebral bodies should be barely visible because they have the adequate amount of water and the balance. So you should be able to barely see them, not too easily. If you are able to see them easily, it's over-penetrated film. If you cannot see them at all, it's under-penetrated film. So for the sake of clarity, I have just zoomed in to the section of the chest X-ray and the cardiac section, and you can barely see the intervertebral discs. So it means it's adequately exposed. Finally, coming to the business part of this video, or the real business part of the chest X-ray review, a systematic approach, which is step 2, ABCDE plus review areas. In terms of ABCDE, it stands for A for airway and mediastinum and hyla, B is for breathing, which is lungs and pleura, C is the cardiac silhouette itself, D is the diaphragm and everything below it, and E is everything else, which includes bones, soft tissues and devices. Then we'll finally touch on the common blind spots, or the real crucial areas, or the review areas where you can have subtle pathology. Coming on to A, which is airway, mediastinum and hyla. In airway, we are talking about the trachea and the carina, which is a bifurcation of the trachea to right and left main bronchus. So if you look at the annotation, which I have done myself on this the chest X-ray, the yellow line in the middle is the trachea. It's central, it's not deviated. So if it's deviated, always look at the rotation and the R in the right that we just discussed previously. Normal angle of the carina should be around 60 to 70%, which in this case it is. Anything wider than more than 90 degrees is considered abnormal, and if it's more sort of acute, above 90 or 100 degrees, then think of the left atrial enlargement due to any cause, for example, mitral stenosis or any valvular pathology, which pushes the left main bronchus upwards and hence makes the angle sort of bigger and wider. So that's the splaying of carina. The green lines are the hyla and the mediastinal contours. So look for the hylar density, if it's symmetrical or asymmetrical, lymphadenopathy, for example, in sarcoidosis. You can look at the pulmonary arteries and also the mediastinal contours. After the airway, we'll come to B, which is breathing. That includes the lung and the lungs and the pleura. So in terms of the approach, as we already said, you need to compare both sides, right versus the left, and so on horizontal grade as well as vertical grade from apex to the base. Look for asymmetry in either lucency, which means the air, the black, is it more on one side or the other, and then opacification like soft tissue, which will look more whiter. describe what you see, just like dermatology on from skin point of view. When you have a skin lesion, you describe. So on the x-ray, just describe what you see. So is it airspace specification, which is a better term rather than saying it is consolidation? So airspace specification, describe, is it bronchial pattern, lobar pattern, is it diffuse, reticular, nodular, rather than just saying that it's a mass or consolidation. Yes, the finding may be suggestive of that, but avoid diagnosing just saying that it's a consolidation. Also localize in terms of zones. On the chest x-ray, as we discussed previously, you cannot comment on the lobe because it's a two-dimensional x-ray. It's not a 3D dimensional x-ray. So upper zone is above the first two ribs, middle zone between second and fourth rib, and lower zone below fourth rib. For pleura, look at the, once the lung parenchyma is done, look at the pleura, especially cardiophrenic angles, claustrophrenic angles, apices and fissures. And overall, just ask, is there is a volume loss or volume gain? In terms of the examples on the right hand side, if you just see the opacification example that I have just described. So this is a good description. You can say, if you see there's right-sided diffuse triangular shaped lobar opacification, the right lower zone peripherally, suggestive of possible consolidation. So this is more comprehensive. And you might also see that the right hemidiaphragm is probably the same level as the left, so there's an element of volume loss on the right side as well. The lower diagram, the lower x-ray, is an example of lucency. You can clearly see the edge of the pneumothorax and the distal part, peripheral part, totally devoid of any lung markings, vascular markings. C, cardiac silhouette and mediastinum. What to look for? Obviously, the cardiac contours or the size, the shadow itself, cardiothoracic ratio on a PF film. The hard borders, look for whether they're clear, distinct, or is a silhouette sign positive. We will come to that in the following slides. Looking at the aortic arch and knuckle, and also the mediastinal contours, whether there is any widening or not, and signs of heart failure that we will come to in the following slides. So AP film is not a good way to assess cardiomegaly. This is a clear tip that we have discussed before. In C, we also have to understand about the cardiothoracic ratio. So how to use it, when not to use it. We've already covered. Ideally, you should be using the cardiothoracic ratio for a PA view rather than AP. We have discussed about the limitations of AP. In terms of the rules of thumb, cardiothoracic ratio in a PA view of more than 0.5 suggests cardiomegaly. It's not reliable on AT film. We have discussed about the magnification. Also, if there are low lung volumes that can exaggerate the cardiothoracic ratio artificially, hyperinflated lungs can elongate the heart shadow, so that also may underestimate the CTR. And also the best thing is to compare with previous imaging and the clinical status of the patient rather than just one-off. How do we measure it? Now, if you look at the chest x-ray and a PA film, it should be nice, central, not rotated, not tilted. How you do it is because the right ventricle is more sort of higher up and the left ventricle, the maximum edge is lower down. So you can't compare it side to side, yeah, like in the same line. So think of a midline, the middle line which passes through the center of the spine from the through the cardiac shadow. So that is your reference point. And then you look at MRD, maximum right diameter, maximum left diameter, MLD. And so that is the reference point is from the spinal line. You look at the tip of the right ventricle and the left ventricle. You add them up and then you divide them both, the sum of these two, by the internal diameter, which is the of thoracic cavity from internal ribs. So rib cage to rib cage. So that's the key thing. So if this ratio is more than 0.5, it is suggestive of cardiomegaly. One other point is whenever there is a globular heart, boot shaped, think of pericardial effusion rather than cardiomegaly itself. So again, echocardiography will be very helpful in such situations. Coming to D, which is the diaphragm and below, we look at the domes, which is the shape of the diaphragms, the angles, precisely cardiophrenic and claustrophrenic angles, and also the subdiaphragmatic space in the below the right hemidiaphragm. In terms of the right hemidiaphragm, it's anatomically usually higher than the left by about 2 to 2.5 centimeters, which is predominantly due to the liver. So also look for the blunting of the CP angles, the claustrophrenic angles, which may indicate a subtle or mild pleural effusion. Elevated hemidiaphragm, if the right is too much elevated than the left, then it could be phrenic nerve palsy, or think of something pushing it up. So subphrenic abscesses and all the liver pathologies can sometimes push it up. Also, if it's elevated, is it something pushing it up or something pulling it from above? So atelectasis and other respiratory causes can also be the reasons for the volume loss. Free air, so under the right hemidiaphragm, if you notice a rim of air between the diaphragm and the liver, that can indicate ruptured viscus. Lastly, the E, which is everything else, that includes bones and soft tissue and devices. You need to form any routine for yourself, either an inside out sweep or an outside in sweep, but just follow the same routine. So for outside in sweep, you need to look at the bones, ribs, clavicles, scapulae, that might be a dislocated shoulder, vertebral bodies, proximal humeri. It could be a fracture, it could be a dislocation, it could be a latic lesion, and also at the alignment. The next is look at the soft tissue. That could be surgical emphysema, it could be a breast shadow abnormality, it could be a mastectomy on one side, chest wall masses or opacifications or soft tissue opacification, and also look for asymmetry in both sides. Devices, look at the endotracheal tube, lines, permanent pacemakers, CRTDs, chest drains, intercostal drains, NG tube, and whether the tube is going through going up to the diaphragmatic, subdiaphragmatic space to the left side of the stomach. And also, if there is a device, ask yourself, is the device appears to be in the correct position, and also, is it causing any complication? Remember, the most missed findings are usually outside the lungs, because subconsciously we focus only on the lungs. We think of a chest x-ray as lung x-ray, but it's not a lung x-ray, it's a chest x-ray. So this is a really important tip. The next 3 slides are one of my most favorite in this presentation, so please pay attention. Before you label a chest x-ray as completely normal, you need to look at the review areas and make sure you're not missing any of the pathologies. So look at line 1, which in this case, so the disclaimer is this x-ray is from Wikimedia, but the annotations are mine. I've done them myself. So line 1, if you follow the orange lines, so the orange arrow and then the orange annotations, and the line 1 follows the sequence. So from lung apex, look at any evidence of TB or pneumothorax. A subtle apical pneumothorax can be missed. Coming and then follow the green line to the hyla. So the next orange near the hilum is the next point. So look at the hyla for adenopathy or masses. Coming down from the medial side of the heart shadow, then you've got the third digit 1, which corresponds to the orange dot, which is a cardiophrenic angle. So look for any opacification over there. Follow it along the diaphragm to the costophrenic angle. In that area, you might have a subtle pleural effusion. Then the last line up, sweeping up, is the lung edge. So look for the subtle pneumothorax at the periphery. Line 2, the purple one, corresponds to the heart and diaphragm. So look behind the heart. So there could be retrocardiac shadowing in the left lower lobe, pneumonia, or any mass might be there. So look through the heart shadow. Then look behind the diaphragm. So it could be a lower lobe pathology, a subtle pathology which is hiding behind the diaphragmatic shadow. And also on the left side, it might be abdominal, any other abdominal pathology like gastric air bubble. As we discussed in the previous slide, look at the right hemidiaphragm for subdiaphragmatic air, a subtle rim of air which might indicate a ruptured viscus. And finally, the line 3, which is in green teal color. It corresponds to the bones and the soft tissue, which we already covered previously. Look for any fracture, dislocation, or surgical emphysema. So make sure you make a micro habit of at the end of the whole X-ray, do a zoom in and look for the peripheral sweep of the periphery of the chest X-ray. And the final part of this video will be a quick look at some of the patterns after going through the routine. So in the patterns, we will look at the increased opacity, which means the more whiter shadows like consolidation, atelectasis, effusion, or pulmonary edema. In terms of increased lucency, which means more blacker shadowing of pneumothorax, hyperinflation, COPD, etc. And also some volume loss, so or change in volume. So we'll just quickly review them. Firstly, consolidation, one of the commonest, predominantly pneumonia-like pattern, as we discussed before. Describe what you see. Look whether there are any air bronchograms. Is it homogeneous or no? What zone is it? Upper, middle, lower? Is it peripheral, central? Is it next to the heart border or peripherally located? Silhouette sign will come to that in the next slide. Also consider differentials, which could be infective etiology, aspiration, hemorrhage, or it could be a mass or a malignancy. Let's quickly look at the silhouette sign. What is it actually in English? It's quite It's a confusing concept, so we need to understand in English first. So the Cambridge Dictionary defines silhouette as a dark shape seen against a light surface or a light background. For example, if you look at the distant sky and you can see the mountains or the tree, the shadow. So that the shadow formed by the mountain or the trees is the silhouette of those mountains and trees. Same as a person standing against a light background, you can make out the silhouette, the outline of that person. In a normal chest x-ray, whenever there are normal lungs, so there is air in the lungs, hence the density is low, density of the air, and the soft tissue, for example the heart border and the blood inside is denser, it's liquid and solid, like a heart muscle as well as the blood inside. So the sharp demarcation of a normal cardiac contour against the low density air forms a silhouette of the heart. So, and also silhouette of the diaphragm for that matter, for both. Now, so the presence of silhouette is a normal thing. It's a normal anatomy and a normal feature on a chest x-ray. So when the silhouette is lost, when the air in the lungs is replaced with a higher density medium substance like a consolidation or a mass or something, so that definition of the normal anatomy will be distorted. So the cardiac border will become indistinct, the diaphragmatic border will become indistinct. So remember, a positive silhouette sign or a silhouette sign being present means the loss of silhouette. So this is really, really important. Now, it's a really interesting fact that the silhouette sign is important because it appears in medicine. It is there when something disappears. So the silhouette has disappeared altogether. Unlike most of the other clinical signs, Hoffman sign, Hohmann sign, all of those, Gray-Turner sign, all of the signs are when there is something present. Carpopedal spasm due to hypocalcemia. So if you consider it, most of those signs are noteworthy when they are present. And in this situation, if you see that in the cardiac and the front AP film, you have got airspace opacification close to the heart border. So the distinct heart border is lost. So this means there is a loss of silhouette and hence suggestive of consolidation or pneumonia. The other important pattern is atelectasis or collapse. When do we consider it? Whenever you have the normal anatomical landmarks are distorted, for example, the fissures are displaced or there is mediastinal shift to or away from one side, or if there is elevated hemidiaphragm as we discussed before, more than the physiological cutoff, or if there is crowding of ribs on one particular side as compared to the other side. That's why comparison of both sides is so crucial. Or if there is compensatory hyperinflation of the other normal lobes of the lung, so then you would suspect atelectasis or volume loss. One of the commonest causes is a mucus plugging leading to partial atelectasis in patients with COPD, asthma, bronchiectasis, or elderly patients who have recurrent aspiration pneumonitis, or anything obstructing the endobronchial airways, so any foreign body or tumors. And also it can be a massive compression due to large pleural effusions or pneumothorax or malpositioned endotracheal tube. The next is pulmonary edema, heart failure, one of the very, very important patterns. So what to look for? Look for the vascular redistribution, upper lobe diversion. Normally the upper lobe vessels should not be clearly visible because those are anti-gravity and the pressure should not be physiologically should not be high enough. Then looking at the interstitial edema, is it fluffy pattern, is it diffuse? Looking at the perihilar bat wing opacity, so the hyla will be congested, so the bat's wings, they span from the body outward. So if that is a pattern, that is a bat wing appearances. Also, usually you will have bilateral or sometimes even unilateral pleural effusion. The grade could be mild to moderate, and the heart may or may not be enlarged. In acute heart failure, especially if there's no previous history, the cardiac shadow may not be enlarged. So in acute pulmonary edema without any previous existing cardiomegaly. But again, in some cases, or majority of chronic congestive cardiac failures, the cardiothoracic ratio will be enlarged. Again, chest X-ray is not a good way of assessing. You have to assess other symptoms, signs, clinical examination, wheezing, crepitations, etc. Next pattern, pleural effusion. Predominantly, it's assessed best in upright position rather than supine. We have discussed on the previous, the RIPE regime. The classic signs of effusion obviously depends upon the volume of effusion. If it's subtle, it could be just a blunting of costophrenic angles. The meniscal sign will be positive if it's large enough and the upper level, the upper part of the fluid, the level itself forms a meniscus, so it tracks up around the lateral chest wall itself. If it's a massive or severely large volume of pleural effusion, it can lead to pressure effect and the underlying lung can be totally collapsed, and or the trachea and the mediastinum can be shifted to the other side. In supine films, you may have just a diffuse haze and apical capping. The fluid layers they track posteriorly because of the gravity. If uncertain, you can do ultrasound scan to differentiate between a collapse versus pleural effusion. Next pattern is pneumothorax, really important. What's the difference between a space which is full of air and a normal lung? Because the lung shadow stops short of the peripheral thoracic cage, and hence that space of the pleural, the pneumothorax space will be devoid of the normal lung markings and the vascular pattern, because the vessels will stop short of the periphery. Like in this situation, if you could just track the blue arrows, that the deep dark black part of that of pneumothorax is devoid of the normal lung tissue. And we have discussed in the previous one of the previous slides is you can have a deep circus sign on supine films for a small pneumothorax. There might be mediastinal shift away and depressed diaphragms. Usually that's a tension in pneumothorax physiology, but look at my acute dyspnea series and modules that in the other videos we have discussed. If you are clinically suspecting tension pneumothorax, you do not wait for a chest x-ray to confirm. Needle thoracocentesis is the first line of treatment in that situation. Now, some of the pitfalls is the skin folds and scapular medial border of the scapula may confuse you as a pneumothorax edge, but in that situation the lung markings will still track over the scapula, and also the scapular border doesn't come down up to the diaphragm, so it just curves laterally. So if you look closely and magnify the chest x-ray, the scapular border will not be tracked up to the diaphragm. Just a quick word about lines and tubes. In terms of tubes, the endotracheal tube ETT, the tip should be just 3 to 5 centimeters above the carina where the trachea bifurcates, especially if it's a neutral head position. The NG tube should be tracked along the middle of the spinal shadow up to the diaphragmatic crura, and it should be tracked below the crura towards the left side towards the gastric bubble. If it doesn't cross the diaphragmatic crural junction, it means it could still be higher up in the esophagus or airways or lungs. So it's very difficult to differentiate. So it has to be below. Tracheostomy should be midline and appropriate depth, and chest drain, the side hole should be within the pleural space. In terms of other lines, the central venous catheter tip should be just above the SVC right atrial junction. The PICC line should also be in the superior vena cava. Pacemaker ICD leads, they should be expected to course along the right atrium and right ventricle, because that's where they are pacing and sensing. In terms of complications, especially if it's immediate post-procedure, you definitely need to look at the pneumothorax, hemothorax, or malposition. Or a practical tip for the urgent findings, which is a call now list. If you find any of these conditions, do not delay, immediately report to the ordering physician, or if you are a physician yourself, either act on it or seek attention from your senior members of the team. Number one, tension pneumothorax. Obviously, before chest x-ray, it should be diagnosed clinically, but if it's a large pneumothorax with some element of shift on a chest x-ray done for whatever reason, do not delay. Severe pulmonary edema, rapid assessment of the patient's vitals, oxygen saturation, and stability is really crucial. Free air under the diaphragm suggestive of a ruptured viscus is one of the surgical emergencies of acute surgical abdomen, so do not delay, please. Massive pleural effusion or hemothorax, again, there is a risk of decompensation, compromise, hemodynamic instability, so that's really crucial. Mediastinal widening after trauma could indicate ruptured mediastinum, or if there is mediastinitis or free air just around a mediastinal free air, that again should alert any aortic injury, or you may require a CT chest or CT aortogram for that matter. Same as ruptured aortic aneurysm or dissecting aortic aneurysm with central crushing chest pain, difference of blood pressure in both arms, etc., etc. So again, this is a clinical emergency. Similarly, malpositioning of the tubes. If someone is an ICU patient or a high dependency unit, or even a normal patient with a tube placement and it doesn't look right, it has to be reported straight away. So these are some of the real important parameters to consider for red flags. Just a practical tip about how to report a chest x-ray. Looking at the technical qualities, the PA, AP, erect, supine, any ripe issues which is rotation, inspiration, projection, and exposure, and also lung adequacy, lung film adequacy. The findings describe systematically A, B, C, D, E, and the review areas which are not to be missed. Always check right versus the left side, compare both sides. Comparison with previous chest x-rays is really crucial, and impression in a final actionable statement. So a typical example, you can come with the a statement like this: right lower zone consolidation consistent with pneumonia, no pleural effusion or pneumothorax, heart size within normal limits on this PA film. And the last slide, just some final tips. I'm not going to go through everything again, but when you open a chest x-ray, just go through the same routine: patient details, RIPE, ABCDE, comparison of the review or missed areas, and comparison with prior x-rays, and whether it's routine or urgent escalation. So this is your take-home message. How to build your skills, especially for medical students, junior doctors. So read at least 10 normal chest x-rays, know the pattern, know the normal anatomy, and then look at the abnormal films with reports. Calibrate your eyes, try and look at the pattern recognition. That's important. And keep a missed finding list and revisit weekly. So just keep refreshing your knowledge. The more you see, the more you learn, the more you get, and it just becomes a pattern recognition. And good luck. So please comment on in the video about your experiences, anything that you would like to discuss in future, and we'll be happy to take your questions in the discussion section. And do subscribe and like, and please stay tuned. Thank you.